and these are the two first ones. Does the Hegenberger retractor cause tension while suturing? I would say to the clinicians that if they use it to close the vagina, it shouldn't cause any tension on the suturing. I use it myself for the full repair when 8 out of 10 times. And then there are a few women where I do think there is a little bit of tension in the very last suturing, in the very last sutures that you place, just as you're closing the last part of the perineum up to the vagina. But you can certainly close the full length of vagina, and also most, I would say 80% of the perineal body. And in most women, you can actually leave it in and close the full repair with the Hegenberger in place. There will be a few women where it does pull the tension on the suturing, and then you just say to the clinicians, well, then take it out, and then it has still been benefiting for you, or it has still been a really great tool for you for 80% of the repair, where it's the most difficult. That means far back in the vagina and also the deep tissue in the perineum. So that is the answer to if there's a high tension on the suturing. You also refer them to the app, because there we do have 9 videos, and one of the videos there is actually how you fold the retractor and how you pull tissue down to kind of give yourself more tissue to work with. So tell them not to be afraid to actually, change the position, rotate the Hegenberger, but I mean, fold the wings together and pull down the tissue while you're suturing. You can also, I did that yesterday. I had a very complex tear where the tear kind of ran a little bit up close to one of the sides of the Hegenberger, and I had to fold it twice during the repair and actually pull the tissue down so I could still have a really good view. That's one question. The other one is, why is there only one size, as we have different patients with different anatomies to deal with? Well, we do have different patients to deal with, but the whole tunnel, the vagina, just after giving birth is actually very similar to each other, no matter whether you have a Caucasian woman or you have an Asian or African woman. It is very much the same. It's a very soft tunnel organ that has been distended for the birth, and the hormone of the pregnancy makes the tissue very elastic, which is why we can give birth. The hormones of the pregnancy also makes the ligaments in the pelvic bone section also more adjustable or soft. That means that the whole pelvic bone area or the whole bone structure can actually give way to give the baby. When you fold the Hegenberger retractor together, it is about 4 centimeters by 4 centimeters, a little over an inch, and most women can fit that very easily. Remember, there's just been 2.5 kilos, 3 kilos the other way. And also the length of the Hegenberger should fit most women. I haven't had anyone where I couldn't push it in place. The few women, when it comes to the bone structure, can actually have a very narrow arcus, as it's called. That means a very high bone structure. But there you simply have to place it further in, and then the top of the Hegenberger will lock behind that pubic bone. But I haven't had any women, no matter where of the part or which part of the world they're from, where the Hegenberger wouldn't fit. And some clinician will say, well, that's a very cool product, but we don't really need it as we have enough hands around. I can be a little cheeky here and say, well, I would like to work in that hospital where they have enough hands, because I have certainly not met many hospitals where we had enough hands. And also you have to look at it from whoever those hands belong, because that person who holds the side for you, or that person who holds the retractor, or do have 2 shoulders and do have 2 wrists, and they're going to last for many, many years. So even though it is something that you used to do, look at what you're actually asking someone to do. It is very strenuous for your shoulders and your wrist to hold the side for somebody. Another aspect of this is look at from the female perspective. How many female actually likes to have 6 fingers in the vagina giving birth, or just after giving birth? It is not ethical, correct? It is painful, and it certainly is not something that is very surgically safe. You know, you're handling a bloody needle. It's a very bloody tissue you're dealing with, and you have very poor visibility if you have somebody to stand and hold a SART for you. So that would be my answer to that. That's multifactorial. There is the woman perspective of being sutured with 4 to 6 fingers in her vagina, and there's also the ergonomics of whoever you are asking to do it, and couldn't those hands be doing something a little better, more useful than to hold vaginal tissue aside. You would never see that in the OR, for instance. You would never say, well, let's do a cesarean section. Let's have somebody come in with your hand and hold aside. Another question is, why does it cost so much when I have done this for years with 0 additional cost to our budget? I can only say that the women are going to be a lot more expensive for the budget if you don't do it right the first time. Modern women, the women that are coming in to deliver today, they are asking for a proper care all the way through labor delivery. That includes the suturing. Women of today are afraid of 2 things. 1, they're afraid that something is going to happen to their baby. And 2, they're going to have a tear that's going to have consequences for their life for the rest of their time. So it is a small cost to a very important procedure that the women are going to live with for a very long time. So if the hospitals invest in that, they are also investing in the future lives of these women. I know it has not been something that's been budgeted before, but you could look at how many ultrasounds are we providing for women today. Here in this country, we are providing them 3, sometimes 6 if they're smokers. You know, what's the cost of that? Nobody's arguing about that. But when it comes to repair, it's not supposed to cost anything, but still it is 3 organs that you are suturing or you are checking. It is the bladder, the vagina, and the anus, something that we have to live with every day for the rest of our lives. So the modern women are going to be looking for the departments, the hospitals that are taking this seriously. Somebody will say, I'm nervous about using the retractor without my sales rep present. We can suture any time of the day. What resources do I have to help help me, and who can I call? First of all, please put a strong emphasis on the app. It is videos on real women. They can listen to if it slides out, you know, what do you do if there's strong tension on the sutures, how to place it and how to remove it. That is a very good thing to have really implemented in the department. Another thing is to actually focus on some super users in your department. Find some, if it is midwives, there will always be midwives in your department that really, really loves to suture. Go and train those specifically so you have 4 or 5 super users in the department. And the same thing with the young doctors. That can be, the young doctors are very eager to use the Hegenberger, and they feel that they have that third hand. They always need it when suturing. So the app is something that they can use 24/7, and during the daytime they should be trained by their super users or have a super users on at night. That is something that, so that the rep, somebody who is an extended arm of the rep in the department, is very good. I'm sure you all know that. What are the risk factors of inserting the retractor as far as causing more trauma to the patient or more tears? It seems like it's a bit invasive. When it comes to something being invasive, I think 4 to 6 fingers is also very invasive, and the fingers are unpredictable. That means whoever has those fingers are going to be moving them around. The Hegenberger is going to be gently placed. It's going to be sitting still. For whoever is suturing, but also for the clinician, for the woman, this is a much better experience for both parties. There's no risk of the Hegenberger causing more trauma if you just gently place it over where the tear is, as long as you're not moving it around, turning it around inside the vagina. It goes in and comes out very easily. You can compare it to other metal retractors that we're using. That has to be inserted in, and you actually turn it inside the vagina. There is also, you could say, risk of damaging the tissue, but it's very, very minimal. I haven't seen it yet, and I certainly do not hope to see that. But when it comes to somebody saying that it's invasive to place something in a woman that's giving birth, then you can say, well, it is a lot higher price if she doesn't get a full repair or a proper repair. But always compare it to the fingers. The fingers are in many clinicians seen as more gentle than an instrument, but fingers are just a human retractor, and they are certainly a lot less predictable than an instrument that you're placing. Why is the retractor not reusable? We did try and make it in, no, we didn't make it, but we were thinking of making it in metal, but the flexibility, to get the flexibility in metal would have to cause the Hegenberger to be very, very thin here. And that would be very difficult to remove. The risk of actually cutting the vaginal floor open or up would be way too big. So a soft plastic, soft flexible plastic device is what we chose, or what I decided to do in this case. And the women actually like it. They don't feel like it's a very surgical instrument. They don't have that sound of metal. It is a very light, when you show it to them, they're not afraid of it. So that's another user positive things for the users. Somebody will say, most of my tears are superficial. I don't think I need a retractor for suturing. When you have this kind of clinicians in front of you, there's two ways. Either you can decide not to take that battle with that person, but because we do know that 65% of most tears is second degrees, which involves muscles. And there's also episiotomies, the cut, that also involves muscles. And then you have the third and the fourth degree tears, which are very complex tears. But try and dig into what is a superficial tear to you. Is that a second degree tear, or what is it? Because in my world, a superficial tear is a first degree tear where there's no muscles involved. But a second, third and fourth degree tear, that does involve muscles. And those muscles we're using to keep continent, urinary incontinent, but also air and fecal continence. So in my book, that is not superficial. I think all the second degree tears, from second episiotomies, third and fourth degree tears, they should have exactly the same level of focus on identifying the muscles and closing them correctly. So there's two ways. There's going into the details about what is a superficial tear to you, and do you actually know that 65% do have a second degree tear or an episiotomy, or simply pick the clinicians in the department that actually knows what they're doing and takes it a little more seriously than this person here.